This is Maher Abbas from Dubai, and it's my honor and privilege to be presenting at your meeting in Manila. Today's topic is going to be on surgical intervention versus stent decompression for malignant large bowel obstruction. I have no financial disclosure to make. I am both a colorectal surgeon as well as therapeutic endoscopist, and my hope would be that I give you a balanced approach to this topic. Now, approximately 4 years ago, this made the news here in the Gulf. Basically, I had stented perhaps the oldest patient in the region, a 100-year-old Emirati gentleman presented with large bowel obstruction and metastatic disease, and I was able to successfully get him out of the hospital without the surgical intervention and without a stoma by the use of an endoscopic stent decompression. Of all patients with colorectal cancer, approximately 1/5 will present with an obstructing lesion. Obviously, if you come from a system where there's not as much screening for colorectal cancer, that percentage will be higher. And in a system where there's a widespread use of screening modality, that percentage will be a little bit lower. And when patients present with an acute large bowel obstruction, there are really two issues that we need to address. The immediate issue is that of the large bowel obstruction, which has a certain morbidity and mortality associated with it. And there are obviously the oncologic consideration of the underlying disorder, and we need to try to balance both of these issues. In terms of treatment option, as surgeons, we have a variety of operation that we can utilize for an individual patient. We can resect either by performing a segmental versus a subtotal resection. We can put the bowel together with the possibility of a proximal diversion, or we can bring an end stoma. In some select cases, we don't resect at all. We just divert with an ileostomy, colostomy. And on rare occasion, we can perform internal bypasses from a proximal area of the distended bowel to a distal area that is decompressed. And in terms of endoscopic options, we can decompress internally either with a stent or a colonic tube. Now, we do know from numerous studies, including the 3 listed here, that emergency colorectal surgery carries significant amount of morbidity and some mortality, especially in the elderly patient. We also know that stoma formation rates remains high despite all modern surgical advances, even in young people. There's a lot of data to suggest that significant number of them end up with fecal diversion. And we do know, especially in the elderly patient and those in the setting of cancer, approximately half of them will never get reversed for one reason or another. And in this study from a group in Spain, looking at 83 patients who presented with obstruction, we know that the overall and major complication occurred in 67 and 32% of the patient and were associated with higher ASA class, and patient received blood transfusion. And nearly 1 in every 10 patients who underwent emergency colorectal surgical procedure end up dying. Older age, obviously, and a high Apache 2 score were a significant risk factor. Endoscopic stenting has gained significant amount of momentum in the last 20 years and had become really a viable option with a high technical success rate. It does have several short-term advantages, including less stoma formation, a shorter hospitalization, fewer complication, fewer death, and in those patients who require chemotherapy, they can reach chemotherapy faster. Now, this is very important. Early in my experience in Los Angeles, I looked at my own data with the first 52 palliative stent over a 5-year period. In my cohort of patients, it's important to note that nearly half of them died within 4 months. So we know a lot of these patients are terminal, and 60% of patients died within a mean follow-up of 5 months. So endoscopic stent is very attractive since the majority of these patients are really terminal, and rather than spending their time in the hospital recovering from surgical issues or going home with a stoma, we can decompress them successfully with an endoscopic stent. Now, we do know from many studies, including this one published in Archives of Surgery from France, that the time to resumption of chemotherapy was much faster in patients who got stented versus those who got operated. Furthermore, the percentage of patients who received chemotherapy was higher in patients who underwent a stent compared to those who underwent an operation. Now, the question become, as our chemotherapeutic agent become more and more potent, what is the impact of endoscopic stenting on survival in oncologic patient? And also, we need to know that as the patient live longer, what are the chances that they require additional intervention, either endoscopic or surgical, if they did receive an endoscopic stent as a first intervention? Now, this is very important because endoscopic stenting is not without complication. In this pooled analysis published about 20 years ago, and granted the technology has changed since then, but some complications remain the same. About 23% of patients sustain one or more complication, perforation approximately 4%, migration of stent with reobstruction about 18%. There was 0.5% mortality, which is still very favorable compared to the figures I quoted you earlier with the emergency surgery. And obviously, this interesting study pulled together 44 studies with nearly 1,200 patients. Now, these are a summary of multiple studies that have looked at that from around the world, from Europe, United States predominantly. And if you see the rate of complication long-term varied from 8% up to 45%, perforation, erosion, and bleeding, as well as obstruction and migration of the stent, which was reported by the majority of these studies. And this is not without the need for endoscopic reintervention. As you see here, about anywhere from 3% to 43% of patients who undergo a stent placement will require endoscopic reintervention at some point. In terms of the need for surgical intervention, these are also several studies, the largest of which came from the Mayo Clinic, my alma mater, looking at 168 patients, and about 1 in 5 patients, 21% required operative intervention if they received a stent in the beginning. And what are the concerns about the stent data? Obviously, most of the data is retrospective in nature. The question is the impact on cancer outcome. For palliative patient, that's not as much of an issue. There, it's the endoscopic reintervention and subsequent operative intervention. But the important question is for potentially curable patient, is there a negative oncologic outcome if the patient undergoes a stent placement in terms of tumor dissemination, or if they were to sustain a perforation, do they have a higher likelihood for a relapse from an oncologic standpoint? Now, we do have some limited prospective data. This is a multi-center randomized clinical trial that made the news in Lancet Oncology about 10 years ago. And these are patients who came in and got randomized 1-to-1 ratio when they presented with acute left-sided malignant colonic obstruction. 25 hospitals participated in the studies, predominantly in Netherlands. There were 98 patients who got randomized, and due to the interim analysis, which showed an increased 30-day morbidity in the stent group as it pertained to perforation and stomatic leakage, the trial was suspended, and the recommendation was against endoscopic stenting in this setting. And in this multi-center randomized trial of 9 centers, when they looked at the acute left-sided malignant colonic obstruction, again, they compared 30 patients who underwent surgery versus 30 patients who underwent stenting. There was no difference noted in stoma formation rate and no difference in the mortality, morbidity, and length stay. This was really surprising considering that many retrospective studies have shown a benefit in favor of endoscopic stenting. And due to the high technical failure rate of 53%, the trial was closed prematurely, and a lot of the technical failure were either inability to deploy the endoscopic stent or perforation. Now, I must say that this data is really an outlier for most of us who've done a lot of endoscopic stenting. The technical success rate typically is 80–90%. And a meta-analysis combining these two randomized clinical trials with the two additional randomized clinical trials looked at 234 patients over a 20-year period. These patients underwent endoscopic stent as a bridge to surgery. The majority of them had left-sided malignant large bowel obstruction. The primary and secondary outcome were primary anastomosis, stoma formation, mortality. The secondary one were the anastomotic leak, surgical site infection, and 30-day reoperation. And then meta-analysis reported technical success rate of 71%. Clinical success rate, meaning not only one is able to decompress the patient technically, but has a good result long-term. 69%. Perforation rate was 7%, with silent perforation occurring in 14%, or that is like microperforation. And in this meta-analysis, comparing stent to surgery, higher success for primary anastomosis with a relative ratio of 1.58 in favor of the stent, with the lower stoma formation rate. However, there were no difference in permanent stoma rate, mortality, anastomotic leak, or 30-day reoperation with SSI. It's important to note that 3 trials had stopped prematurely. Emergency surgery had higher anastomotic leak. However, stent complication led to a higher 30-day morbidity. Now, in terms of long-term survival, they've been predominantly retrospective data. This study, again, looking at acute left-sided malignant obstruction, comparing 48 patients who underwent a stent for bridge to surgery versus those who went directly to surgery. The 5-year cancer-specific mortality was higher in the stent group, 48 versus 21%, and the 5-year overall survival rate in patients who presented at a curable stage was lower in the stent group. And that study basically raised a lot of concern about using stent for colonic decompression in patients who are potentially curable. Now, the Dutch stent into trial looked at that topic as well, and they compared 32 emergency operation with 26 stent patients. The stent were unsuccessful in 6 patients who end up in surgery. Some of these patients had wire stent perforation. It's important to note that in the study, the local regional intestinal disease recurrence were higher in the stent group, 28 versus 50%, and in patients who sustained perforation, those oncologic outcomes were much worse, with 83% recurring. Now, do we have any basic science data? This study looked at dissemination of tumor cell in venous blood, but they looked at a group 1 patient who underwent colonoscopy for benign condition, group 2 patient who underwent colonoscopy to stage colorectal as part of a workup for colorectal cancer, and group 3 which underwent endoscopic stent placement. And when they measured the peripheral venous blood before and after this intervention, there was an increase in cytokeratin 20 MRA expression, which is a biomarker for tumor cell in patients who underwent endoscopic stenting. Now, all of these studies and data have led the European Society of Gastrointestinal Endoscopy basically recommend against prophylactic use of stent in patients who come in who are pretty curable. A stent as a bridge to elective surgery was not recommended, especially in patients who are viable and potentially curable. And this basically slide illustrate that. However, when it comes to palliation, stent decompression was the preferred method. So for patients who are potentially curable, not advisable. For patients who are in need of palliation, endoscopic stenting could be very useful. Now, from my perspective, malignant colorectal obstruction obviously is a very complicated, complex issue. Stent have supporter and opponent. We do know, however, that surgery is not perfect. It's not without significant morbidity and mortality. We also do know that the technology continuously is evolving. When I first got involved with the endoscopic stenting approximately 20 years ago at the Mayo Clinic, the first patient was stented. We used biliary stent. When I went and practiced in Los Angeles in the early part of my career, I was utilizing mostly esophageal stent due to the lack of availability of colonic stent on the market. But since then, the technology has improved significantly, and we are starting to have more and more option in terms of colonic stent. So as a colorectal surgeon who has lived in this area, I provide a customized approach to the topic of acute obstruction of the colon from a malignancy. I take into consideration the age of the patient, the fitness for surgery, also the presentation, whether there is any risk for perforation or peritonitis, and the stage and location of the cancer. So this is my algorithm, and if you forget everything about this talk, I encourage you to look and focus on the next few slides. Basically, if a patient comes in, they're old, frail, or have significant comorbidities, my preference is basically to go to surgical intervention if there's any evidence of perforation or peritonitis, or if they have a very low tumor in the distal rectum. These patients are not suitable for endoscopic stenting. However, if the patient does not have a very distal tumor involving the lower rectum, and they do not have any evidence of peritonitis, then my preference is to go the endoscopic route. If the patient, however, is in a good shape, is not frail, is not very old, does not have significant comorbidity, decision is basically based again, do they have any sign of perforation or peritonitis, and is it a very distal tumor? Obviously, other parameters that can come into the equation are whether they have a sphenic flexure lesion, which can be very technically difficult to stent, or if they have complete occlusion without any lumen visualization, and that's something we can study the suitability of the patient for stenting with a gastrograph enema first. But if the patient obviously is completely blocked, has a sphenic flexure lesion, a very distal tumor involving the distal rectum, or they have perforation or peritonitis, I would advise to go directly to surgery. Otherwise, I base the decision whether the patient is curable or not. If they are fit but they have metastatic disease, I'll go the endoscopic route. If they fit and they have a potentially chance for cure, then I will go to surgery. And that is basically shown here. Now, if you're interested in the topic of stenting, these are some of the publication I have in the literature. The top study from 2017 tells you everything you need to know about colonic stenting, how to do it, and when to do it. And if you want to know about predictors of outcome, which patient do best long-term and short-term, the bottom study, also published 2017, will provide you with some very useful information. So in summary, ladies and gentlemen, we do know that both surgery and endoscopic decompression are both a good option for patient with malignant colonic obstruction. However, the judgment of the surgeon and patient selection is of paramount importance. It is important to know that endoscopic stenting should be done by experienced therapeutic endoscopist, whether it's surgeon or gastroenterologist. It does require a significant amount of technical expertise to maximize the outcome for the patient and minimize procedure-related complication. And in a closing note, it's important to know that this area will continue to evolve as we are provided with new technologies and new tools, but also as the care of the cancer patient continue to evolve with better chemotherapeutic, immunologic treatment in the future. And I want to say, as someone who's been twice already to the Philippines, Philippine and Philippine General Hospital are really dear to my heart. I've been twice there. The last time we organized a beautiful therapeutic endoscopy course. I do hope to return again and to continue to collaborate, educate, and learn from Filipino colleagues in Manila and the various cities of the Philippines. And these are, again, the references that I showed you earlier.